Now, let me ask you this. Do you think that the federal government just kind of took on that role of kind of molding EMS early on because there were no professional groups to really give that feedback on how it should move forward? We're still very young in EMS.
Okay.
Yeah, we'll address that one.
Flag on the flag. All right, we're not young. We're middle-aged. 44 years ago, there was a paper written. Everybody knows about it. It was the white paper, quote unquote. It articulated that the leading cause of death between 16 and 35 was traffic accidents. And back then, when Congress did what Congress does best, they get upset about something, they pass a law. They said, okay, we're going to help fix this problem. We're going to start saving people on America's highways. And so they built literally a system, or supported financially the development of individual systems through grant process around the country to do that. Now, I would suggest that, like the fire service, because of prevention activities, because of seat belts, because of safer cars, because of airbags, no longer are 50 or 60% of the people in their prime age dying on highways. A very small number die on our highways in comparison to what they used to. Trauma is no longer the leading cause of death on America's highways. So it's been very successful, but it doesn't address and quit addressing the evolution of medicine, which is really what, that whole thing about emergency medical services. And as a result of that process, we're now placed in a position where the evolution of systems has been so individualistic around this country that standardization, it can only occur, in my opinion, based upon the science and the medicine. You're never going to see standardization in operational protocol. You're never going to see it in construction of whatever system design you want to call your EMS system. None of those things will exist in this country for a lot of different reasons, not the least of which is the fundamental issue that each state is a separate government entity. We are the United States of America. We are not one nation. We're one nation, but we're made up of states. We're a union. And because of that fundamental difference, that's why you don't see EMS systems in this country that look anything like the UK or the Australian system or the German system or the Chinese system. So that has, makes it very difficult. This is not easy. This is difficult to create standardization. And if you can't do it by virtue of policy and regulation, which is what governments do, in our business, I would suggest the only thing that's left to us is the medicine.
That's the opportunity for standardization.
Exactly.
It's what color you want to paint your vehicle, how you want to roll it down the street, how many people you want to put on it. Again, that's a community level decision.
The patient needs to be the focus. We talked about it last panel, and it comes up all the time, is no matter what color you paint your truck, no matter whether you're union, non-union, fire, private, it needs to focus on the patient. And like you're saying, it seems that's the one thing we can agree on, is if the medicine lines up, then why wouldn't it be the right thing to do in multiple communities?
I think in words we can agree on it. I'm not seeing that necessarily always in practice, and that's where we need to put our efforts and really start to put our money where our mouth has been, and come together around this concept of treating people.
And if you want to know what the role of the federal government is here, that's it. Okay, we lack fundamental basic research in pre-hospital emergency medical care in this country. Although some is going on and more is going on, the federal government has never supported that sort of research. NIH, for the first time in the history of the National Institutes of Health, will be releasing a sizable amount of money to do pre-hospital care research. Now, we won't see the results of those programs for 3, 5, 7 years maybe, but we're at least starting down the pathway of trying to do real scientific research to determine what is good patient care in the out-of-hospital environment. A lot of what we do in the out-of-hospital environment has never been validated scientifically. And so we face that struggle, but I think that is actually one of the places the federal government has a huge opportunity to contribute to systems around this country, is helping them get to that point where they can say, this works. It's kind of like the aspirin thing. You know, we know what aspirin does for people over the age of 45. It keeps their blood thin, which keeps them from having things like heart attacks and strokes and catastrophic early death. But we don't know those kind of things in EMS. We don't have the proof. Now, we can sit around, but we're finally starting down that pathway, and that is a huge part of the role of the federal government, is to support those sorts of things.
I agree. There needs to be, I think, a more concerted effort to study what we do and how we do it and figure out what some of the best practices are. You know, the classic thing when you talk to a group of people is, you know, why should we have paramedics? Well, because paramedics save lives. Well, prove it.
Yeah,
Right?
there's only one metric they study, because it's the only one you can prove definitively whether we had an impact or not.
And that
Cardiac
is-
arrest.
okay,
Either
but-
they were dead when we got there and alive when we left, or they weren't. But you can't.
Cardiac arrest is fraught with difficulties from a research perspective because you can never have a double-blinded randomized control trial because your
Exactly.
control group will always lose.
And you also
And the
can't.
public would never stand
And you
for
also
it.
can't say that because I was nice and helped the old lady, she had a better outcome. There's really no way to measure most of what we're doing unless we go back, like you were saying, to the basic medicine of it. Is the medication and procedure we're doing having an effect, yes or no?
It transcends these pulse and pressure questions too. It's not just numbers. There's a whole element to this that we sometimes quickly forget, and that's quality of life. You know, how are we affecting the quality of life of patients? More fascinating is how are we affecting the quality of life of the people that are out there trying to improve the quality of life of patients? You know, we're very quick just to forget about ourselves and not worry about it. You know, how many people were injured this past year working in the back of an ambulance? Have no idea. What were those injuries caused by? No idea.
No one
How do we
tracks
fix
those
it?
numbers.
No clue.
Unless it occurs on an industrial facility, then they count it.
No,
or
no,
if
no,
it's,
the-
or if it's on a national highway, right? Anywhere else, we don't keep those stats.
I wrote an occupational
That's the
injury
big-
report. I wrote an occupational injury report for a national organization a couple of years ago, and one of the issues that came up was that the problem is that if you're a firefighter or you're a police officer and you get injured, there's a unique coding mechanism that goes in to code your injury, and you could pull that up on an OSHA 300 log. When it comes to EMTs and paramedics may actually get coded as firefighters, because if they're an EMT firefighter, they'll be coded as a firefighter, but it may be an EMS-related injury. If you're a paramedic and you work for a hospital-based system, you'll be coded as an OHCW, other healthcare worker. So, I mean, that's totally lost and, out in the ether somewhere. And then if you're working for private ambulance service, you actually fall into another specification. And so, it should be reasonably easy to pull up injury report information for EMTs and paramedics, but it's been difficult across the entire industry. Some states collect the information, and this was kind of disconcerting, and I don't want to mention which states, but we did an entire survey. And one state collected accident information, but they wouldn't release it. And when we asked why, they said because when we break it down by private provider, volunteer, fire department, etc., it makes those segments of the industry look bad. Because you can turn around and say, why do private? And this was from the state office. This was from the director of EMS for the state office, and it was like, well, we don't want the fire department to look bad. We don't want private providers to look bad. We want people to feel good in their community. How do I develop reasonable measures of, training and education during the orientation process? How do I know to concentrate my resources on driver training, etc., if I don't have numbers to support what I need to do? And then a benchmark, not only, lateral benchmarks within my organization, but sequential benchmarks so I can compare myself to the guy sitting next to me.
I think right there, I think it just brings up a good point. One of the conversations that we had in our board meeting yesterday was that data is currency. And this is the currency that we're talking about, and it was by Mr. Jeff Miller here. Data is currency, and as you can see, although we're talking about these different areas and subjects, the main thing is that EMS has not collected data. This could be something that the lead federal agency for EMS, that would be their primary role, is to provide us with that level of validation, provide us with that central repository for all this data collection, so we can go ahead and, Dan Gerard, if you're asking for that information that you just said, we just created these benchmarks. We're validating why these are the safety issues involved in EMS, why the standard of care is good. So this is that avocation when it comes down to where we have these different jurisdictions like, and we just talked about this just outside. Jim Page stated it, right? What was that, Greg? If you've seen one EMS system, you've seen one EMS system. And that's the issue. So with the level of fragmentation that's out there, the lead federal agency, data collection, go ahead and be a central repository, then go ahead and distribute that information out to all the state entities, county entities as such, show them the benchmarks and give them a reason why you're doing what you're doing.
And I think it's important though, because that's something that will take a while.
Sure.
And we no longer have a while. The 11th hour is past, we're into the 13th. We have to start taking some serious personal accountability and responsibility at the local levels to start making these serious issues. Because we don't know what's happening, and we don't know, kind of from an empirical standpoint, and again, I'll couch that by saying we'll never know that because those types of studies are nearly impossible in the pre-hospital environment. But there's a lot of stuff we could be doing, and it's not complicated. It's not, 1,000 deep data field sets that we need. We need basic informational data to kind of take the temperature of what's happening out there and then start going back through our local and state folks and affecting these changes. That's one of the things that we hope that this organization can help other people with, and liaise with other organizations and start to share this data back and forth. It's currency, yes, but globally, the EMS data currency is pretty poor. Like, you're upset about the value of your 401k, you should be horrified about the value of your EMS data currency right now.
Yeah, I think that a lot of the difficulty with that too is, you brought up another point, law enforcement. We're integrated into so many different other professions, we're really not unified under our own. And so it's about being able to have a place to go ahead and pull EMS, those people out into, to go ahead and have that ability to go ahead and collect that data.
One of the initiatives that the IAEMSC is currently undertaking, with some generous support from a longstanding friend of EMS, is exactly what we're talking about here. It's the development of a Healthforce surveillance system. We currently are in beta. We're vetting it and making sure it works appropriately. But we anticipate probably within 6 months that we will be offering this system to anybody in EMS who wants to register their department and submit data on workforce health and injury and illness and deaths. And we can start then getting some data. Hopefully we will get lots of data. And then we can start pushing out information that says, okay, last quarter, out of X amount of reports, this was the leading cause of an injury or an illness, or this was the leading cause of death. And we can start identifying what some of these issues are, have some numbers behind it, so that we can go and make a cogent argument with our legislators that we need to address this safety issue or this health issue. This is why.
It will also give us very, very valuable information on the human factors side. And that is that it could be that these super cool things that we're using out there, the whiz-bang 6,000 device that everybody has to have, they may not be set up exactly right for us, and they may be contributory to certain types of injuries and things, but we just don't know because nobody's watching.
We don't know what to ask for because we can't say what's wrong.
And
Is that an accurate statement?
it's
Yeah. Well, the other thing is too, think about it, if you look back at the IOM report, on EMS said that there's approximately 18 million patients transported annually here in this country. Does anybody else think that number's wrong but me? Think about it. New York City transports 1.2 million people. So you mean to tell me New York City makes up 1/18 of what the IOM said actually was transported? LA transports just about 1 million. Geez, they're another 18. Houston, they're right in the same neighborhood. Chicago, they're right in the same neighborhood. So when you start doing this real quick, we start coming to the realization that even one of our premier research institutions in this country couldn't get their hands wrapped around such a basic, simple piece of data as how many patients get moved by ambulance in this country. And that's that's the depth to which we are absolutely buried in. I was given a plaque a long time ago by my boss when I got a promotion and I started having to do payroll for my EMS system. And it said, "In God we trust, everybody else brings data." And we don't have it. And so until we start capturing that, we really have nothing to go to our national legislators with to gain support for, things that, the Justice Department has done for years for law enforcement personnel. The U.S. Fire Administration has done for years for firefighters. We can't tell you how many people died in EMS last year. Now, we got anecdotal reports and we track them from the news media, but is that really the whole number? No. We know that. We know people get missed. That's not fair to those people, and it's not fair to the industry to fail to understand why those people died doing this job. We need to improve upon that radically, and if there's anything that the people out there in the world in this business should really get into, it's driving the data issue, getting data collected, sharing data.
Accurate reporting.
Right. There's nothing super secret here.